Hello everyone, my name is Ahmed Raslan. I'm a professor and interim chair of neurological surgery at 𝐂𝐻𝐶U, and I'll be giving you a talk today about deep brain stimulation for pain. I'm also the president-elect of the North American Neuromodulation Society, and I would like to thank the organizing committee for this symposium and giving me this opportunity to speak to you. These are my disclosures and they are not relevant to this talk. History of deep brain stimulation goes as far as 1870, when the first direct electrical stimulation of the cortex in animals was performed. Then later on is performance of stimulation of the septal nuclei was performed until the invention of stereotactic apparatus. And there are some landmarks here, which are the stimulation of the frontal tracts in psychosurgery in 1948, and the direct stimulation in the 60s, and the stimulation of the periventricular periaqueductal gray for treatment of chronic pain in the 77, and the work of Benabid and the invention of the frame. So the story goes a very long way. As I talked about the historical context, Heath in the septal region in 1954, caudate nucleus by Irvin in 1966, periaqueductal gray, PEG, PVG, AIIMS in 1976, the VPL of the sensory thalamus in 1973, and the anterior cingulate cortex by Spooner and Bocard in the last 15 years. That is an important history for the treatment of pain. I would like to also emphasize that deep brain stimulation of pain is currently not approved in most countries as a clinical treatment, but is performed on medical necessity basis or under special approval in some cases in some countries. Let's talk about the failed United States Medtronic trials. Medtronic models 3380 superseded and was rolled after 196 patients enrolled. The teen central trial reported in 1993 46 persistent pain relief at 1 year. The Model 3387 trial had also poor enrollment, and in recruiting only 50 patients, 11 central trial reported in 1998, 16% only with persistent relief at 1 year. There was a high attrition rate, 70% lost to follow-up, 60% relief with 3380 and 50% 3887 at 2 years if lost patients excluded, which was worthy of FDA approval, but I think it wasn't because it was an intent to treat paralysis. And that failed trial, which included multiple heterogeneous patients, led to basically the death of deep brain stimulation for pain as a viable therapy because of that failed trial. However, there are multiple case series for deep brain stimulation for pain since the 70s. Richardson and 𝐂𝐻𝐫𝐢𝐻𝐞, 30 patients implanted, successful implanted patients 90, Plotkin, Shulman, Young, Hosobuchi, Levy, and Geibels and Kumar, Namani. And look at the percentage of successful initially: 90%, 67%, 89%, 86%, 60%, 61%, 78%, 62%. But if you look at the number of successful long-term, you will find a wide variability. You can see it as high as 77 in the Hosobuchi, and you can find it as low as 12% by Levy et al. But remember, Levy started with actually a 59%. So we have a heterogeneous series, but there might be a signal that deep brain stimulation could work for pain. But pain is a complex feeling that has a somatosensory, cognitive, and affective component. So which component could you treat with deep brain stimulation? And there are multiple networks involved in the perception of pain. These are the main networks color-coded here: the sensory network, which is the S1, S2, the VP thalamus, and the periaqueductal gray. The cognitive network is the prefrontal cortex and orbitofrontal cortex, and ACC and insula composing the affective component of pain. These three areas constitute a framework of thinking about potential networks to be targeted by deep brain stimulation. Currently, there isn't one system that targets all three or even two, but there are now the trials. I'm going to go over the presentation of relevant trials and studies that looked at deep brain stimulation for pain based on these networks. Again, this is the ACC and posterior thalamus. These are the potential DBS targets for pain: VPL, VPM, and PEG. These are potential targets. So the game plan today is to go over somatosensory target studies, affective network studies, cognitive network trials, cluster headache, and closed loop and biomarker. Let's get going. Somatosensory targets for DBS: periaqueductal gray, which is 2 to 3 millimeters lateral to the third ventricle wall at the level of the posterior commissure, and VPL or VPM, depending whether that's the facer or arm, medial to the internal capsule at the level of the posterior commissure. This is a study by Bocard and Alex Green from Oxford looking at the long-term outcome for deep brain stimulation for neuropathic pain. And the patients, neuropathic pain is refractory to medicine for at least 2 years. Patient refractory to poorly tolerant pharmacological treatment, referred to clinician to a multidisciplinary team, definable organic origin for pain, neuropsychological evaluation, excluded psychiatric illness and absence of surgical contraindication. This is the 12-year cohort analyzed, and here you see here, 61 has long-term follow-up from an initial 197 patients. The people, only 76 had a full DBS implantation, with 11 patients explanted after initial DBS trial. Look at the visual analog scale. It remained up to 1 year, statistically significant reduction of the visual analog scale. There is an improvement of SF36. The visual analog scale mean reduction was 5 points, so that's a significant. So this was considered a very good trial. However, this was a retrospective analysis. If you look at it at more than 4 years, you can see that the still statistically significant visual analog scale at 4 years, not as good as the initial years, not highly statistically significant, but it is statistically significant. So yes, there is waning effect, but if you look at 4 years, there is more or less an efficacy sustained, but not as the same magnitude. So this is a study that looked at the use of PEG as well as VPM for deep brain stimulation for intractable neuropathic pain. This is reported by Sharona Ben-Haim, Zaman Mirzada, and Bill Rosenberg. These are the cases of Bill Rosenberg. There's 8 of them. And the most important finding here is they have a very good result for facial pain, which can be replicated by other authors as well. And the important thing is that some of those patients, it took them up to 9 months for reduction. This is a very good reduction of a visual analog scale. Post-op, is significant reduction. You see the 1, 1, 2, 3, 4, nobody more than 5. But look at the patient with the orange. It took them up to 9 months to show reduction of pain after initial high. So that just gives us a message that for those patients, you may want to wait before you declare the system a successful or not, and you would want to wait for up to a year, in my opinion. Now let's move on to the effective network modulation. The rationale for effective network modulation is the following. There's frontal lobotomy patients have reported less pain. Cingulotomy patients receive relief and and the narcotic withdrawal. That's possible with cingulotomy. That's the work of Ballantine and Foltz and White. And PID and blood flow evidence by Jones, Talbot, and Casey and Honda all showed increased blood flow to the anterior cingulate cortex during pain episodes. So this is a case series for deep brain stimulation of the effective cingulate networks, also by Tipo Aziz and Alex Green, the Oxford group, and Sandra Bocard. And these are 16 patients, composed of 6 patients with failed back surgery syndrome, 4 patients with post-stroke pain, 3 patients and other patients with the variable brachial plexus injury, and the 3 patients with either spinal pathology, hidden injury, and unknown. 7 had previous VPM DBS, and 9 had widespread pain, and that's the reason why we didn't go to the thalamic target here. And this is the stimulation electrode. This is the mid cingulate, the dorsal cingulate. The stimulation parameters were high by 5 volt and 130 hertz and 450 pulse width, so that's a high energy, and that is the location of the electrode. Early outcomes were good, so initial success was good. However, I'll tell you what was the problem with this. This has worked actually, and it's very good, but there was a specific side effect that led to a reduction of the use of this one. You can use a sensing enabled system for ensuring safe anterior cingulate deep brain stimulation for pain to make sure that you're not overstimulating and causing seizures, because the problem with this 3 patients has a new onset seizure disorder. And the idea here is that could we use a system that senses the anterior intraictal discharges to prevent the overstimulation of the anterior cingulate cortex, to allow us to provide this to patients. That remains a very reasonable suggestion and very reasonable proposal for this. But currently, the problem with anterior cingulate cortex that prevents its wide use for deep brain stimulation is the seizure induction, which occurred in 3 to 16 patients. So that's not an insignificant, about 20%. So DBS for anterior cingulate cortex, 16 patients treated, reasonable relief and quality of life, unexpected seizure possibly avoidable with ramping stimulation and sensing. Let's talk about the insula. This is the work of Segerdal at Nature Neuroscience in 2015. Direct electrical stimulation of the insula was reported by Mazzola for face pain, anti-acute pain symptomatology also for Brooks, and tracking ongoing tonic heat pain showed that the insula is involved. These are all basic science trials that showed that the insula is involved.
And this is the style, the trail spell labeling, measuring of cerebral blood flow and ipsilateral dorsal posterior insula. Activation correlates to the degree of pain. So this was used preoperatively to target the area. And also the work of DEMO, which is electrical stimulation of the insular cortex, so as a novel target for relief of refractory pain. This is an experimental study in rodents. This is the effect of insular stimulation in thermal nociception. That's the work of Dini. And there are multiple studies and registries that look, including the insula, which includes Chervel-Carr as an open loop DBS. So these are the electrodes in the insula. So we talked about the somatosensory network stimulation. We talked about the affective network stimulation. Now we're going to talk about the cognitive network modulation. This is a very important study by the Andre Machado and Cleveland Clinic Group and Scott Lemke that published in the Annals of Neurology. And they wanted to do a randomized clinical trial for deep brain stimulation for post-stroke pain. And this is the screening. And screen the patients, have a baseline assessment, and you provide them with DBS and DBS on and off. And the target here was ventral striatum and ventral caudate, which is a target that's used in OCD. And this is maybe reducing the anticipation and fear from. And ultimately, they had 8 participants into studies, and here are 10. Here is the subjects, demographics of them. All of them had ischemic stroke pain in the brainstem and the medulla and temporal horn and thalamus. So multiple etiologies and sensory deficit in the painful zone was either severe to moderate, and motor deficit in the severe zone was moderate to severe. And a lot of them were either left or right. And here they showed stimulation and the pulse amplitude and pulse width and frequency. And he showed that the visual scale, the more than 50% improvement, the percentage was low, but the cognitive network score shows reasonable reduction. And BDI has a depression inventory, showed a significant reduction on the BDI and the depression inventory here. So the MADRS score and the BDI, the cognitive and affective components, has decreased. However, the sensory reduction was not evident. So this was a failed study, but it showed that you could reduce the affective and reduce the cognitive component of pain. Let's talk a little bit about a cluster headache, because that's a unique case, and this is about a stimulation of the posterior hypothalamus, which is an autonomic control center for treatment of a very unique condition called cluster headache. And she had, initial very good reports, a very good outcome in the 5 patients. But there was a death in one of those patients later on with the stimulation due to hemorrhage, which reduced the use of this. But that remains also an attractive target for select patients. There's also an area of the ventral tegmental area stimulation for refractory cluster headache, and this is the work of Ludwig Zrinzo and Harith Akram. So that's an important target and shows significant reduction of pain in cluster headache. And so that's another area for cluster headache. So cluster headache is an entity because it has an autonomic component. So either the posterior hypothalamus or the ventral tegmental area. Lastly, I would like to let you know about the closed loop deep brain stimulation trial for refractory chronic pain by the Eddie Cheng group in UCSF, trying to identify a biomarker for pain and change the state from a painful state to a normal state through all dimension. And as such, they've been able to identify the first in human prediction of chronic pain state using intracranial neurobiomarker that is detected by a sensor in the subfrontal lesion, so in the occipital cortex. And you can see the difference between low pain and high pain in the blue and red. Do we have a neural signature for pain? We may, for chronic pain, and that signal could be in the beta range. That's the work of, again, Alex Green and Tipo Aziz, characteristic of local field potential correlating with pain relief. So in this particular condition, beta power correlated with pain relief. And there is this study here for the efficacy of pain intervention using deep brain stimulation for neuromodulation. So that's another trial. This EPI-1 is a phase 3 pragmatic assessor blind randomized control for DBS for persistent spinal pain. So that's an ongoing study as well. These are a patient from mine that I implanted the electrode in the VPM and the PEG, and we looked at the frequency band and the power spectral density, and we identified as beta as a marker of severe pain. So we may have some conflicting view whether beta represents pain activity or chronic pain. So if it's chronic pain, beta increase may reflect reduction of chronic pain, but episodic pain might be represented with high beta power. You can look here at the peak of pains when the pain score is above 9. You can see the peak between 20 and 30 hertz. So this is a power spectrum DLC. This is now accepted for publication in neuromodulation. You should see it soon. So DBS for pain was the first indication historically for DBS. It's currently not FDA approved. There are 2 trials aborted in the early 2000s. There are multiple targets, inconsistent results. The indications need to be honed, done largely outside the USA for neuropathic and phantom pain. Newer approaches and multi-network targeting may be promising. Thank you very much.